Good morning, good afternoon, good evening, everyone. Absolutely delighted to see so many people attending December's Data Science Roundtable talk. I'm absolutely delighted to introduce you to Dr. Danyal Khan, who is our speaker for today. I'll do a very quick introduction and then Dr. Khan, I'll turn it over to you. Dr. Khan is a neurosurgical resident at the National Hospital for Neurology and Neurosurgery in London. He is a PhD candidate in surgical technology at University College London. His work focuses on the clinical translation of computer vision to improve neurosurgical outcomes. He has more than 100 peer-reviewed publications, including in high-impact journals such as Nature Medicine, and his work has been showcased internationally via Reuters and the BBC. Dr. Khan leads the UCL Global Coaching Program, an evidence-based initiative that leverages AI-enhanced video analysis to break down traditional barriers in surgical training with a focus on sustainable impact in low-resource healthcare settings. His PhD research in pituitary tumor surgery applies machine learning to recognize procedural steps and intracranial anatomy, translating clinical insight into tools that elevate surgical education. He is currently supported by a doctoral fellowship from the National Institute for Health and Care Research UK, a PhD fellowship in health research from Google, and an honorary research fellowship from the Royal College of Surgeons in England. Dr. Khan, we are thrilled to have you here today. Over to you.
Thank you so much, Rachel, Carmel, and the rest of the SDSC team. And great to see so many of you here and some familiar faces. My name is Dan, and as Rachel has kindly introduced me, I'm a neurosurgery resident in London and a PhD student. I've been working on computer vision applied to pituitary surgery for about 6 years now, really at the initial explosion of this space in neurosurgery. Our team published some of the first models within pituitary surgery, and it's really nice to be able to reflect on that today and talk a bit about some of the different directions we've gone in and some of the lessons we've learned. I'll try keep the talk relatively short, sort of 15-20 minutes, to leave some time for questions afterwards. So I'm going to just set the scene a tiny bit with talking a bit about pituitary surgery for those who aren't medics. The pituitary gland is a gland that's between your eyes and a few centimeters back. It's the size of a pea, and it's called the master gland because it produces hormones that controls many other hormone producing organs in your body, like your adrenals and things like that. When things go wrong with it, and that means that these hormones can either be too high or too low, and that can have effects all over your body. And as you'll see soon enough, that although these tumors tend to be smaller than tumors elsewhere in the body, they can press on some really important structures. And because they're located in the middle of the brain, and that's what I'm going to try to depict here in a moment, they can be really difficult to access. What's shown here on the left is the first recorded pituitary surgery, at least in modern times, and that's being performed by Victor Horsley, who was the first ever neurosurgeon employed in the world, allegedly, at this hospital in Queen Square, where I'm talking to you from. He's performing this operation through the skull, and one has to lift up the front of the brain to access the pituitary. And you can imagine, even if you're not from a surgical background, that sounds pretty gruesome. And although we sometimes have to do that for some tumors in real life, you do risk damaging a lot of structures on the way. Like with many surgical specialties, our specialty of neurosurgery has been revolutionized by technology. And you can see on the right, I'm trying to depict a camera going up somebody's nose. This is called an endoscope. It's a camera on a stick. And this yellow beam here is pointing towards the pouching in the bone called the sella, where the pituitary gland and therefore the tumors usually sit. And you can see that by accessing these tumors through the nose, you can avoid all that injury to the brain in theory. And actually, this has made completely revolutionized approaches to pituitary tumors and tumors in this region. Now, despite all these advances, we've done some work to basically monitor the outcomes of every unit in the UK. So that's about 35 units. And this confusion matrix is to show on the y-axis different surgical techniques, and on the x-axis is showing different centres. Here I'm showing 27 of the 30 odd. And you can see that there's in each category, so matching technique to centre, there's a different depth of colour, and the colour depth is meant to be the incidence of a particular type of complication, leak of brain spine fluid from the nose. And what I'm trying to get across here is there's loads of different ways to even do one small step of the operation. And you can see across centres, actually, there's a huge heterogeneity in outcomes. So these kind of high level decision makings of what sort of operation you perform or what sort of steps or equipment you use still make a big difference to patient outcomes. And patient outcomes are quite different centre to centre. The other challenge is that within those steps and within those techniques, it's just it's an operation that is intrinsically fraught with risk. So here I'm showing in the middle of the screen as a pituitary gland. Now this is a cadaveric specimen, so you can see things are nicely dissected. To either side, these structures are the carotid arteries, and if one was to injure those, God forbid, somebody could have a stroke or die. And these white structures here are the optic nerves, which control your vision. So you can imagine that if there was a tumor here and it began to enlarge, they can often encase these arteries and distort the normal anatomy, and they can often press on these nerves, causing patients to lose vision. Now, when if you've got a cadaver and you've got hours to dissect it, you can see how all of these structures are very easy to delineate. In real life, here's another cadaveric specimen. It looks a bit more like this, but again, I would say this is relatively easy to see the anatomy. You can see the cella in the middle, the arteries here covered by a layer of bone, and the nerves here. But when you're doing this on a live patient, this is often covered in blood and snot because we're going up to the nose, and because the tumor is growing, it can distort and destroy a lot of these structures. So there is a challenge within these steps to be able to perform these surgeries safely without damaging these other structures. And because of these outstanding issues, we did a international consensus study with various patient groups and charities to figure out what was important to patients. What do they want us to tackle next? And one of the repetitive themes and one of our top 10 priorities set by patients was to explore technologies. And they specifically mentioned imaging, robotics, and AI. And for us, AI and specifically computer vision enthusiasts, there definitely is. We're at this exciting intersection where technology has enabled us to analyze types of data which we haven't before been able to analyze in a scalable way. And so we were presented with this opportunity, as I say, just near to a decade ago, where we could start exploring this in operations and moving beyond radiology, where this field really had its boom in medicine. But before we really got into it, we stepped back and said, well, hang on, before any other type of research, what's really important is for everyone to agree on what outcomes we should be measuring, what things we should be measuring, or what things we should be researching, but also within videos, how we should structure or tag these videos so that everybody is using a common language, and so that we have some sort of template to base this AI model training on. And this is another international consensus study that we did, and I've taken a little snippet of this, but you can see that, as you're probably aware from the literature, we identified the core steps and the instruments needed, key anatomy, and some things that can go wrong. And we did this for the entire operation, again, ready to set the scene, to guide us as to what we should all be annotating when it comes to videos and when it comes to applying computer vision to videos. Here's a diagram, I think, of the first model we published, just coming up to 5 years ago, which was convolutional recurrent neural network in series, and was used for recognizing what phase and step of the operation was occurring in endoscopic pituitary surgery. So only referring to that first column on the left diagram. We got very excited by this, and in other fields such as general surgery and ophthalmology, they were deriving metrics from this automatic recognition, presenting them back to surgeons and getting some really interesting results. So we thought we would be able to do the same. So use this step recognition model and present these automated performance metrics back to surgeons to see whether there is any potential clinical or training impact of it. Here's a few examples of things that we looked at very early on. So on the left, I'm showing you different steps of the operation and an idea of their, central tendency and spread. On the right, I'm showing you, an index operation. So number one, how long it was, and how the sequence of these steps were compared to other common patterns. We also explored, before I got into it, we also explored loads of instrument-based metrics, following training a model in parallel to recognize the instruments being used. And we experimented with a lot of these and presented various different metrics to surgeons. And it might have been in part a limitation of the type of AI models we were able to train at that time, or the limitations of our data set at the time. But we landed on something quite simple. For the metrics that we presented back to surgeons, the things we found most helpful was presenting with the simple traffic light system when a step was performed quicker or slower than the median or average of the rest of our data set. And similarly, presenting some independent OSATs, and what that is a validated surgical skills assessment. And that was done by a blinded reviewer, back to surgeons. And we would bring this to surgeons in our unit, of which there are 3 pituitary surgeons that perform pituitary surgery regularly. We'd bring this in a quarterly coaching meeting where we present a few videos, present these metrics, and then we would use this as a way to discuss what was done well and what was done poorly during the case. And, reflecting on it at the time, I thought, okay, when we published this paper, we really kind of stressed the AI aspect. But with time, I've realized that actually these metrics, they're not necessarily telling us granular things about the operation. But to be honest, they probably acted more like a social lubricant, in the sense that it created a culture of being reflective on operations, operative videos, and maybe focusing in on certain parts of the operation and being able to open that discussion with a colleague. Oh, hey, let's look at the hemostasis a bit more closely. How did you find that? That sort of thing, without it coming across as confrontational. And it sounds really silly, but surgeons famously have very fragile egos. And actually, something so simple was a real game changer in terms of our microenvironment and our culture. And when we ran this program, we ran it initially as a pilot over 6 months and published some of our data. And here, what I'm trying to show you is that our surgical performance sort of tightened up in this pink intervention period, allowing for a couple of outliers. And you can see that on average, on this validated skill through a blinded assessment, we were scoring higher across each phase. And this was reflected in a change in outcomes, specifically in CSF leak, length of stay, and anterior is a hormone deficiency after this operation. So it's really interesting to reflect on such a simple application of this sort of technology, having these changes in the way that surgeons were interacting with each other, and therefore potentially having a change, accepting the hundreds of confounders that could be part of this, but potentially having a change in our teaching culture and ultimately our clinical outcomes. We along the way then explored loads of other applications, and this was in parallel with various other advances in compute for edge and cloud computing, various infrastructural improvements in our hospital, and a kind of wider appreciation for the different types of models we could robustly build and run in real time. So here's one example that we used to show, and I think the video is frozen, which is a bit frustrating. No harm. It was just one thing that we explored was this idea of using these very high level step analyses to show what the next step might be. And well, that's probably not so useful for the consultant surgeon. For trainees, being able to anticipate the next step and think about that, and maybe associated with that information, anticipate the next instrument needed and have that ready, get the nurses to have that ready. We theorize that those really simple applications could make a clinical impact. Similarly, simple things like presenting, how much time is left during a case to the anaesthetist might inform them when they would like to start tapering down the anesthesia or help with kind of workflow throughout the day. So there were all these other theoretical applications which we've explored in some parts, but with time I've kind of become less convinced of their true ability to impact care, at least in our pituitary surgery example. I'm sorry, I'm going to have to pause for a second. I'm getting the wheel of death on my PowerPoint, and I don't know whether it's frozen for you guys or just for me.
I can see it still.
Yeah. Okay. Okay. Is it progressing for you? I'm sorry. Is it frozen?
The screen I can see right now is decision-making support for the entire surgical team.
Okay. All right. I'm sorry, I'm going to have to stop sharing for a second because I can't. I just have to shut it down and start it again. While that's happening, I can continue to ramble. And all I was going to say is that, it's been a learning point when we mapped out all the different models that we built with the steps, the instruments, the time remaining in the anatomy. It's been a learning point for me to try and map that to each stakeholder in theatre and try to double down on the areas where we felt that there might be maximum benefit and also where we felt that it made most sense to translate. And where we've actually landed is on this, serendipitously, I'm going to pass it again, so I'll show it to you, is on this idea of navigation. So moving away from these high level things about steps, like here on the left, and decision making and all the training that comes afterwards, and moving a bit more into the case itself. And what that essentially looked like was getting a large data set, pituitary operations in real life, and doing some semantic segmentations for structures. This is a very early model that we published, I think, about 2 or 3 years ago. You can see it trying to highlight the area in blue in the middle where the tumor is, and which is the operative target in this case. And it's trying to highlight with some various symbols and other masks areas where you'd want to avoid or respect. Now, if this is a very common depiction that you would see in the computer science literature, but if you present this to any surgeon, they'll be very quick to tell you that this is kind of useless in its current form, at least for deploying within the theatre. With that in mind, and I'll get back to how we tackled that, we thought, okay, again, can this in its simplest form, that is presenting a mask of where one actually should do the operation, open the bone and look for the tumor, can that in its simplest form have some sort of impact? We did what I call a digital simulation. That is a computer-based study where we got neurosurgeons of various experience levels, from residents all the way up to experienced consultants. And we asked them to identify this operative target, the sella, with and without AI assistance. And what I'm trying to show you here is that on the bottom row of images, which is showing you each image is showing you a different case. On the bottom row, if you compare it to the row without AI assistance, you can see that these predictions, or these agreeability maps, which are an aggregate of all of the different outlines that were drawn by the participants, you can see that they're all tightening up, and they're centering around the ground truth, demonstrating that some sort of, even this really basic AI assistance showing this mask is helping people to orientate themselves and recognize the core part of this of the operative anatomy. Similarly, what was interesting, and this has been reflected in a lot of the literature, was that juniors, that is people at the junior end of their training, benefited the most, and that makes sense, right? If you're already quite certain, and then get presented an AI mask, which you may or may not disagree with, you're probably, if you're confident enough and you have enough experience, you probably just stick with it. Whereas if you start off with a baseline less amount of knowledge, then there's a value gain, a very easy value gain for these AI systems, providing there's some level of accurate. Now, the focus of my PhD has been taking things from the digital world and honing in on this particular example of AI, anatomy recognition, and trying to bring it into theatre. And that brings kind of crops up loads of different challenges. One of the challenges is, if we reflect back on the video I just showed a few moments ago, I mean, that's useless in theatre. That'll distract you, and I'm not sure, it was too jumpy to be helpful, and it was showing the important structures as X's instead of outlines. The other thing is that there's no way that would have been able to run in real time, and actually we didn't have the gizmos and gadgets to be able to do that at that stage in our theatres. We've switched to from an edge computing approach to from a cloud computing approach to these edge computers through collaboration with NVIDIA, and we've done a lot of work as to designing this interface so that it's actually usable for surgeons during an operation. And that work to make it usable was kind of more like product development work as opposed to pure research, although we did it in collaboration with a human computer interactions team and human factor specialists at UCL. But it started off, and this was humbling, starting off with really simple things of, how should we display these segmentation outputs to surgeons? Do they want masks, heat maps, outlines, points? At the time, there was this big push, and actually a lot of the grants that were given to us, governmental grants to support this work, were around this idea of having this smart assistant that recognized the steps, like I tipped my hat to earlier in the talk, recognized the steps and then would automatically display this anatomy when it thought the surgeon needed it most. Or, for example, when the instrument went inappropriately close to these arteries on either side, it might show up and warn the surgeon. Well, when we actually talk to surgeons, and it's quite embarrassing not to do this actually before the grant, when we actually talked to them and tested this, they didn't want any of that. They wanted to be in control, and they wanted really minimalistic displays. And that makes sense in retrospect. And it talks to a wider theme of moving towards simplicity across all spokes of these sorts of model deployments. And I think particularly for the usability aspect, I think because of cognitive overload, right? Like if you're performing a procedure, you're particularly if you're still in training and it's already taking up a lot of your cognitive capacity, you want to be in control of the information flow towards you. We already have so many other gizmos and gadgets, neuronavigation, which is linking what you see to MRI images, and Doppler to sound out these blood vessels. We already have so many inflows of data to us as surgeons, and people are talking about their weekend in the background and all sorts of monitors are beeping, etc. That being in total control of when you're ready to receive that information is really important, and balancing that information overload versus giving you the salient points is a really tricky balance to strike. Similarly, we thought, okay, it's all well and good presenting these outlines, but nobody's really looked at what information we should be giving surgeons to supplement these outlines, so that they're interpretable. And we scoured the literature, looked at various different methods, from saliency maps to these similarity scores, nearest neighbor analysis, etc., etc. And what we landed on is basically surgeons like to know the certainty of the model. And you can calculate this in very different ways, very tokenistically by just taking model weights, or through Bayesian approaches. But you can get these confidence maps that we've been generating, or just a simple number per structure. And the idea behind this is, again, it's with this surgeon-centric design of what they want to know, and their confidence in the confidence in the AI prediction was the thing that they felt added the most useful information on whether they want to trust what's being shown to them or not. We've set up a really simple mock operating environment. It's really rough and ready, and we now have a model like this running in real time. We get repetitive feedback from surgeons, and there's already quite a few features here that we've updated since this old video. But this is just to show that actually we've had this switch our models most recently to make them run in real time smoothly. We've had to switch the edge computer device, monitors, everything. We've had to change a lot of things on the Holoscan environment that is supported by NVIDIA to make this all run in real time and to get the most simplistic UI possible that is useful for surgeons. We're planning a first-in-human trial hopefully soon at Queen Square, just battling some regulators at the moment. But we're really excited, and my reflections on all of this is that it's very interesting that we started and a lot of our grants were for really complicated, very smart tools, very Jarvis-esque from Marvel. But more and more, we've just been gravitating towards simplicity to get this into clinical use. So we're hoping to get this, as I say, in the first-in-human trial at our hospital for training and for clinical decision support over the next couple of years. I have a lot of people to thank, but I see I'm coming up to time. I'd be grateful for any questions, and thanks again for the opportunity.
Wonderful. Thank you so much, Dr. Khan. I'll send it over to those attending. Any questions based on what we've just seen?
Either really clear or really messy.
I thought it was super clear, what it's worth.
Daniel, impressive work. What's your background with computer vision, and how did you build your team with engineers and computer scientists?
Yeah, really good question, and something I've been tossing and turning a lot on. So at the start, it's about 6 years ago, I used to do a lot of the coding myself. We started off with quite a humble data set. We started off with just one engineering collaborator. It really then just spiraled from there with a few very helpful and well-timed grants. We were able to expand our team rapidly so that now I very rarely have to do any of the work under the hood. And my role has largely been kind of directing to the clinical questions that we think we could add most value to. So I think if I was to, when people ask how to set up a collaborative group like this, I think from a clinician standpoint, it makes such a difference having a well-curated, approved and gone through all the governance hoops for a data set. And from there, if you can find a capable engineer within your ecosystem, it's the best way, I think, to pull resources. Now our team's quite large, as you probably saw from our last slide, and our group model has been that every level, so whether it be from group leader level to a doctoral student level, we're all paired in a 1-to-1 ratio with a computer scientist colleague. So that's really been the journey, and it's been really hard now to resist wanting to do a lot of the stuff under the hood again. So and it's becoming, the barrier to entry for clinicians is reducing, right, with so many assistive tools. I have so far stood firm and resisted the temptation only because I'm also training as a surgical resident, and I've been humbled a few times that I'll never be as good as my computer scientist colleagues at building this at a high level. So yeah, I've landed more as the rudder on the ship as opposed to the person doing the rowing.
Thank you. Yeah, it seems like maybe the hardest part about all this is not just building this body of research, but building the team so that you can then create this body of research.
300%. I sometimes, you see those memes of these project managers, and I sometimes feel like that in the sense that, you are constantly pushing things with a wider team, and building the right people in that team is super important.
How was the process when you were trying to get direct feedback from surgeons to change the visual interface for the computer vision models so that's more useful lessen the way? Like, is it just kind of asking surgeons individually, or do you do some sort of formalized survey? And how do you work with your engineers who can help change how invasive the computer vision model is to the surgeon's field of view?
Yeah, again, good question. Because of a lot of our collaborative research, we're quite spoiled for having good access to surgeons around around the country. We started off to get a lot of the low-hanging fruit with these digital surveys, which are basically just running models on short video clips and presenting them via surveys back to surgeons. We got a lot of the big and common sense changes there. Really, the more useful part was having a mock operating suite in our hospital, and getting surgeons to basically do trials of operations with this real-time AI assistance. And we used in the human practice world, there are things like think aloud protocols, and they have a whole series of checklists and operational frameworks for how to glean largely qualitative data from surgeons in action and post hoc. And that's probably where we've made the most nuanced and kind of granular refinements to our approach. And then the next bottleneck has been there are things that are actually very easy to do from a dev point of view, but in parallel, NVIDIA have been developing their HoloScan kind of ecosystem. So we have a weekly meeting with a representative from NVIDIA to basically take things from the general dev world and to apply it to their specific ecosystem. So that's a bit of that was initially a bottleneck, but now is quite a smooth thing through regular meetings.
Thanks. Great work.
Thank you.
Hi, Daniel. I just want to say thank you. This was really great. I appreciate your time. I was wondering if you could bring back up actually that slide about you had like the assessment of the different phases and then how well that helped with a certain outcome. I have a lot of questions of this.
Oh,
Sorry.
this one. Yeah.
First of all, sorry if this is like a basic question, but can you tell me what OSAT stands for, what that represents, first of all?
Oh, yeah. I'm sorry. I did rush through this. I think this was maybe around the time I started getting the wheel of death and got distracted.
Yeah.
OSAT stands for Objective Structured Assessment of Technique or something like that.
Okay.
Simply put, it is a scale with multiple domains, so like fluency of movement of instrument, economy of time, respect for surrounding structures. It goes through key surgical domains, and you get a ranking of sort of like 1 to 5 in each of those domains.
Okay.
It was, I think, derived from simulation and general surgery research, and we've modified it for pituitary surgery to make it more specific for pituitary surgery, and also to make it specific for video-based review, because you'll see components of it that require some discussion with the surgeon, but this is being done in a blinded fashion by somebody independent from our team, so that's obviously not possible. So that's what the scale is.
Yeah.
We break this up per phase. And that is in part a practical decision, because we often find that, well, simply put, like sometimes the trainee or the resident will be doing the nasal and sphenoid phase. Sometimes, they'll do the sellar phase, or there might be a fellow there as well. So the operation is usually cut up with different operators, and we felt that breaking it up into these chunks better captured that did different parts of the performance. It was often really hard to give a video level rating because of that. So yeah, that's what it is in a nutshell.
Okay. And then I have some other questions. Sorry. So the way you're evaluating them, is it linked at all to the, either the outcome or the size of the tumor or something like that, so that they're being evaluated a little more like on a scale that's useful?
Yeah. I glazed over this, but we have different sections, different subgroups that are so that we can do some sort of case matching. So we have what's called like extended approaches or giant adenoma approaches, which would be more extensive operations as one category. We have standard non-functioning adenomas, which would be, medium size and what we would call an index case as a middle category. And then the final category we have are microadenomas. So these are tumors that are smaller but tend to produce hormones. And there's various surgical nuances, but they end up being quite different operations. You can't really it's not like for like with a non-functioning often. So we do to answer your question, we do split it up into we feel matched together clinically. We have sorry, go on.
No, go ahead. No, finish.
No, I was just going to say that one of the next natural step for us for a lot of this was to try predict outcomes. And we've been trying to do that without this intermediary step of having to label steps or having to label OSATs to be able to predict that here on the right. And the long story short is, with the addition of video data, so far we haven't been able to outperform the standard statistical or ML models that use text numeric data or radiomic data just yet. But it is an area of interest for us, and I wonder if it's a model limitation or just a data set size limitation more than anything else. And actually, SDSC would probably be better placed to do that research. Actually,
that was perfect. You just answered my next question, which was, what do you envision being able to do with this, kind of this sort of data? So that was perfect. Thank you.
Yeah, no problem. Thank you.
I was surprised a little. Just one more comment. I was a little surprised that you said that you didn't think that. I mean, I understand what you're saying, that you didn't think that panned out as well as you wanted it to, or that experiment went the way you wanted it to. It did seem to have like a little bit of an effect on the results you're looking on, the OSAT result you're looking at. But I think you're right. I think the next step is more predictive analytics of how of outcomes. So that's interesting. Thank you.
Yeah, and just to add to that, maybe I think there is value in kind of going deep a bit more and getting some more granular. I know you guys have been working a lot on instrument-derived metrics and things like that, and so if we and trying to get at more, more atomic action segments or things that tell you a bit more than these very high-level steps. But again, we've hit a bit of a wall with that. I haven't found too many interesting relationships between all of these data-driven metrics and signatures to outcomes, but it's another thing you guys would be really well placed to lead, actually.
Okay, Dr.
Awesome, I agree. Thank you.
We had a question submitted during registration as well, so I'm not sure who it's from, but I'll just quickly read it out. How is Dr. Khan managing routine clinical duties as well as research?
Yeah, not very well. It's the short answer. We're quite lucky in the UK. There's an option to basically extend your training by doing an enfolded PhD, and that's what I'm doing. So I still have clinical commitments, so usually a theatre list per week and a clinic per week. But then in the rest of my time now, I do research. I'm in the second of at least 3 years of my PhD. So even with that 1.5 day commitment, I have to say it's quite challenging, particularly because we work in a big team, and I feel like I split my time between project management and actually doing my own work and real work. But my answer to this is always the really generic things of being organized and having a good support system and working in a good team. And I'm afraid I don't have a magic pill that will change anyone's life, because I'm struggling.
All right. No, thank you for sharing that. I'd speculate. I wonder whether that was submitted by a US clinician, and maybe there's a difference there between the systems. Okay. All right. Well, I've just glanced at the time, and we've run a little bit over, but that's great. Folks, we're now going to move into the internal part of this discussion. So we're going to say goodbye to all of those who are external to SDSC. Thank you for attending, and look forward to seeing you at future DSRTs. And that